Welcome to this explainer. Today, we're diving into something pretty fascinating. We're tackling a topic that sits right at the messy intersection of a massive human crisis and, well, incredibly rigid medical bureaucracy. We are decoding the clinical pathways of addiction. Basically, we're going to demystify the exact medical coding that literally unlocks substance use treatment for millions of people. Getting a grip on this system is absolutely crucial if you want to understand how care is actually delivered and accessed in the real world. To really grasp why this matters, we have to zoom out and look at the sheer human scale behind all this paperwork. The Substance Abuse and Mental Health Services Administration, SAMHSA, reports that a staggering 28.2 million Americans are currently struggling with a drug use disorder. Just think about that for a second. We're talking about tens of millions of people, and behind every single one of those digits is a real person whose path into a residential recovery facility totally depends on navigating a very strict set of clinical definitions and codes. Understanding this bureaucracy isn't just an admin thing. It literally dictates who gets help and who gets left behind. Okay, let's dive into this. Here is our roadmap for today. First, we'll look at the scope of substance abuse, then how we justify medical necessity. After that, we'll break down the clinical differences between use, abuse, and dependence, and finally, we'll cover coding the path to recovery. Section 1. The scope of substance abuse.
So before we get completely lost in a sea of alphanumeric codes, we really need to understand what it is we're categorizing here. Clinically speaking, we're looking at situations where a patient keeps using a substance even though significant, glaring concerns have popped up in their life. And man, that net is cast incredibly wide. The most commonly involved substances span the entire spectrum. We're talking everything from alcohol and cannabis to hallucinogens, inhalants, opioids, all the way to sedatives and psychostimulants. It's really important to note here that this disorder affects folks using illicit street drugs just as much as those who are misusing legal prescription medications. The bureaucracy actually has to be robust enough to handle the massive variety of this ongoing crisis.
But you know, here is the really crucial bright spot. The source data clearly emphasizes that with effective treatment, patients can recover. They absolutely can overcome their need or desire for the offending substance. The science and the clinical pathways are literally right there to help them heal. But, and this is a massive but, they can only recover if they can actually get their foot in the door of a treatment facility in the first place.
Which brings us to Section 2, Justifying Medical Necessity.
This right here is the ultimate bureaucratic hurdle. How do you actually prove to a giant hospital system or an insurance provider that a patient absolutely needs to be admitted into a residential recovery facility? You can't just walk in and say, hey, they need help. You have to speak the language of the system, and that language is made entirely of ICD-10-CM diagnosis codes. To admit a patient, there has to be a valid diagnostic code to mathematically and medically justify that admission. These codes, they aren't just administrative afterthoughts. They are the literal keys you need to unlock the door to a residential bed. No correct code, no proven medical necessity. And without medical necessity, there's absolutely no admission. All right, Section 3, Use, Abuse, and Dependence. This is where we get into the core focus of this explainer, understanding the clinical difference between dependencies. When doctors evaluate these issues, they don't just toss all concerns into one giant bucket. It actually follows a very specific, escalating clinical ladder, and the exact terminology they use changes everything. So, the baseline on this ladder is use. Clinically, use simply refers to the consumption of a substance without significant clinical manifestations. You can think of this as consumption that hasn't yet triggered a whole cascade of medical or behavioral alarms. It's the lowest rung on the categorization ladder.
Now, what's really fascinating is how just adding a single phrase fundamentally changes the entire diagnosis. We move up from use to abuse. Abuse is defined as the ongoing, regular consumption of a substance, but now, and here's the kicker, we have the addition of resulting clinical manifestations. That is the trigger point right there. The substance is now causing clear, observable issues in the patient's life and health. It's no longer just casual consumption, it's consumption with tangible negative medical consequences attached to it.
Then we hit the very top of our clinical escalator, dependence. This is the absolute most severe and highly specific categorization. Dependence isn't just ongoing consumption with manifestations, it's that, plus a dramatic decrease in the effect of the substance even with continued use. In clinical terms, the patient has built a tolerance, which means they require a significantly increased quantity of the substance just to achieve intoxication. And, furthermore, this is vital. The patient requires continued consumption strictly to avoid withdrawal symptoms within a 12-month period. It is, for all intents and purposes, a complete physiological hijacking.
The contrast is pretty stark, right? You've got basic use on one hand, mere consumption without those significant manifestations, versus full-blown dependence, which is marked by clinical manifestations, severe tolerance, and a desperate physiological need to consume just to avoid withdrawal. Grasping this profound clinical difference between dependencies is exactly what medical coders and clinicians are forced to evaluate every single day.
So, why are we splitting hairs over these words? Why does getting this exactly right matter so much? Because, quite frankly, a diagnosis of mere use just won't cut it. The source text explicitly states that a patient has to be diagnosed with either abuse or dependence to truly justify the medical necessity for residential care. The precise language dictates access. If a clinician casually writes down use instead of abuse when the patient is actually experiencing clinical manifestations, that one simple word choice could completely derail that patient's access to the care they desperately need.
Moving into Section 4, Coding the Path to Recovery.
This breaks down the exact translation process. You can see how the specific substance, combined with the clinical level like abuse versus dependence, maps directly to a totally unique code. For instance, code F10.10, that is exclusively for alcohol abuse uncomplicated. But look down at F14.20. That isn't just use or abuse, that is cocaine dependence uncomplicated. Every single combination of substance and severity gets its very own dedicated tag. It's kind of amazing when you think about it. This is exactly how the incredibly messy human reality of addiction is organized into a searchable, billable database.
But hey, getting that diagnosis code locked in, that's really only half the battle. Once the patient is actually admitted, we pivot over to a completely different set of rules for the procedures they actually receive inside the facility. These are reported using codes from the Substance Abuse Treatment section of the ICD-10-PCS, which stands for Procedure Coding System.
The structure of these procedure codes is actually kind of wild. Despite the vast, overwhelming complexity of human psychology and addiction, every single treatment procedure code in this section neatly begins with the exact same two letters, H and Z. H designates it as a substance abuse treatment, and Z, that's used for the second character, which represents the affected body system. In this specific coding framework, the affected body system for addiction treatment is officially categorized as none, hence the Z. A bit ironic, right? Considering addiction affects quite literally the entire body and mind. But, well, that's the reality of bureaucratic coding for you.
Once we get past that HZ prefix, the rest of the code tells us exactly what kind of intervention is happening. There are exactly 7 types of procedures. You've got detoxification services at HC2, then the vital psychological support kicks in with individual and group counseling, psychotherapy, and family counseling taking up HC3 through 6. And finally, the medical side of things is covered by medication management and pharmacotherapy with HZ 8 and 9. These are the actual actionable interventions that those initial diagnosis codes finally unlock for the patient.
Wow, okay. We've covered a ton of ground today, moving all the way from a crisis affecting nearly 30 million people down to the absolute core focus of the clinical differences between use, abuse, and dependence, and finally into the rigid alphanumeric structures of those HC treatment codes. But as we wrap up, I want to leave you with a thought to ponder. We've seen how absolutely necessary these codes are to navigate the healthcare system, but when strict clinical definitions so rigidly dictate medical necessity and access to care, are our coding systems truly capturing the messy, complex, and deeply human reality of addiction and recovery? It's a really delicate intersection of bureaucratic precision and human empathy. Thank you so much for joining me on this explainer. Keep learning, keep questioning, and I'll catch you next time.